For the phone numbers. I have one.
Okay, we're now live.
Right, good morning, everybody. It's nice to actually see everybody rather than the backs of heads, so it's much better format. Nice to see people in person who are going to be presenting today, so thank you all for attending. Before we start, I need to inform you that this meeting is being live streamed and recorded, so be aware of that, please. I'm Steve Jones, so I'm chairing the meeting. Item 1 on the agenda is apologies for absence. I've got Nick Barnsley with Roy substituting, and also David Linnery gave his apologies. We've also substituted by Nick Towers, who's apologised for delay. Is there any other apologies you need to make?
That seems like it's straight through. No.
Okay, we think we'll have Bernie Benton substituting for Tracy Muffer.
Item 2 on the agenda is disclosure of procurement, disclosure of interest is now. So if anybody thinks they have an interest, please declare it before we go on that item. Item 3, minutes of the meeting held on 16th of May. This year, seems like a long time ago. And they have been circulated, so is everybody seated for the regular meeting? Thank you. All in favour? Thank you. Item 4, we have public question times. So we have one received from Adrian Graham.
I can read the question, Sarah, if you want.
The public question is from Adrian Graham, and it is: given the disappointing start to consultation on the new health hub last autumn, with few members of public aware there was a proposal and Shropshire Council level only alerted by media reports, how does Shropshire Council ensure that an open, fair and transparent consultation will now take place, including the key issue of the location of the building?
Thank you. The response we have is, thank you for your question. From a Shropshire Council perspective, in January 2021, the leader and chief executive were asked to give their commitment to work with partners as a stakeholder in this project led by the CCG in recognising potential opportunities and challenges this proposed model and NHS investments in community and primary care health and wellbeing services could bring to local communities. This work initially involves supporting requests to identify potential areas of land suitable for the proposed hub. In September 21, reference to the Shrewsbury Health and Wellbeing Hub was included as part of a regular integrated care system update to the Health and Wellbeing Board for the first time. At this point, the work had begun to move to a listening and engagement exercise led by the clinical commissioning group. At this point, the Director of Public Health asked for a full integrated impact assessment to be carried out, and members of the board were also asked to come to the Health and Overview Scrutiny. This item was brought to scrutiny for the first time in May this year due to the delays through Omicron and timing and the agendas of the committees. The committee has requested that the CCG now integrated care system has committed to bring regular updates on this issue of primary care more generally through this committee where developments can be monitored. At this previous meeting on the 17th of May, The CCG and the ICS confirmed that to the committee that following the engagement exercise and options appraisals will be developed, which will result in full public consultation. The expectation of this committee is that it will be brought to the committee of launch publication or accommodation in order. That's the response to that question. And then we've got member questions. So, Bernie, you've got a couple of questions.
Thank you, Mr. Chairman. My first question is, in view of the secrecy and admission of inadequate public engagement regarding the huge implications of the proposed Shrewsbury Health and Wellbeing Hub by Shropshire's Clinical Commissioning Group, will this committee, Shropshire Council's health watchdog, request that the new Shropshire Telford and Region Integrated Care Board conducts a formal and robust public consultation on the effects of this radical experiment in Shrewsbury's healthcare, which will result in the closure of 6 local GP practice sites and the location to a single new site.
Thank you. You may recall at the previous meeting of this committee on the 17th of May, a presentation was received from the CCG which clarified that the engagement process was just beginning, and this would take place from February through to May. Further stakeholder sessions will be planned with local members specifically. These have been confirmed for the last week in July. Following the engagement work, options appraisal will be developed, which will result in full public consultation. The committee will request the consultation document brought to the committee before the publication of comment. At that meeting, the CCG confirmed that no practices will close as a result of this work, while the practices will move to coalesce with the new building. The second question.
I'm allowed a supplementary.
You can let me ask the second question.
I'll ask a supplementary first, please. So my supplementary is the answer doesn't commit to a formal public consultation. Will this committee request the Integrated Care Board to conduct a formal, robust public consultation?
I think in the previous answer, we've talked about a full public consultation and we'll come back to this morning, so I think that's already the base of my register.
Okay, thank you, Mr. Chairman. My second question is, will this committee, Shropshire Council's health watchdog, require the Shropshire Telford and Region Integrated Care System to maintain a footprint in each location due to be vacated by 6 of Shrewsbury's GP practices to provide a truly local service to those with poor mobility?
The committee does not have the power to require the ICS to maintain a footprint in each location, to make recommendations to the ICS. The integrated impact assessment will consider impact and risks associated with change in location of services, such as impact on transport, deprivation, social needs, and the impact and risks to those with protected characteristics, and what can be done to mitigate any perceived negative impacts. The committee will consider this assessment alongside the proposals and outputs of the consultation in making any recommendations back to the ICS.
Thank you.
Can I apologise, Chairman, in that Tracy had sent me a message which I hadn't picked up to say she was going to be about 5 minutes late. So Tracy is here. They will slides.
Okay, item 6 is update from the Joint Health Overview Scrutiny Committee, which took place last week. I Heather and Kate were at the meeting as well. I thought it was a very positive meeting. I thought we got a lot of good feedback from it. Gareth was positioned with Smith, you know, what's his name? So director with the new ICS was very positive and gave a good outlook on what has been developed, what's been developed, what's been plan. Actually, some really positive things to be heard, some good ideas, I think, to be fair to them. And all we can do is continue to monitor that and make sure that those come to fruition. Kate, Heather, if you have any comments on that as well?
Yes, I think it was quite positive and he was quite straight with his answers, which was refreshing. We still don't have a timeline for many of these things, and we do need to know when they're going to be delivering. Furthermore, the workforce planning really we need to look at, because workforce is one of the things that's hampering everything. So that workforce plan we really do need to catch up on and make sure that they're moving forward. My reservations, which I said at the meeting, is that we've heard all these things before and actually have not been delivered. So, as you say, all we can do now is check that they do what we say and hold them to account when they don't.
And yeah, I think it was a good meeting in that we got some detail that hasn't been available in the past, including talking about management systems within the hospital to allow for discharge sooner. And I think that felt realistic and promising. I think it was good to have the discussion about the fact that nearly 9% of all A&E people turning to A&E turn up again a week later. And so I think it will be good to look at what the reasons behind that are for. But I think, I just support what Heather says. We need to get the data back to really begin to look at what's happening and hopefully to see future improvements. I'd just like to mention the virtual wards, which are, I believe, starting beginning this week. Yeah, and they're talking about having up to 100 beds, I think. Or was it 200 beds by December? So there are some really interesting ideas, but it's as Heather says, we have been here before, so it would be good to get updates.
And one last thing I just need to add is we were talking about the new discharge systems, which do sound very good. There'll be 3 points of the day when they assess those. He didn't sign up to having enough pharmacists or radiographers or any of those things that actually hamper hugely the discharge at the moment. And he dodged all around that, if Kate remembers. And actually, we need to be checking on that, the 24/7 delivery, which is what they should be doing, because otherwise we will still be stuck in Smith and Friday through to Monday, and it's bank holiday Friday through to Tuesday.
I think it was really, as you said, it was a very productive meeting. It was great to set the scene, you get the work program set out and be very clear about how that's going to link to the ICS work and going forward and the new ICP strategy, and that will be developed by December. I think it was helpful to have a conversation. I think particularly around urgent care, we talked about health and wellbeing board. We've had updates through to joint hospital previously prior to Christmas, but felt like actually we started to get some more of that detail. I think particularly important was to have sight of the dashboards that are being developed. We'd like to see those ready so we can track progress. Also, I think the patient experience. So actually, we might have all these dashboards, but does that feel right? Does it feel different to our patients and our population? I think being able to bring that through will be really, really important.
And so I think just having the open conversations as well, and that was what Chrissy asked for, and I think that was what felt different in the conversation, but actually seeing some of that monitoring, seeing that broad routinely back in that openness was really, really important. And I think that's the principle that we wanted to apply, not just to the urgent care work programme, but actually to all of the programmes that we'll be looking at. And there's and I say there's a really good consensus about what we need to focus on at board, and we'll come back together. So yeah, there's a thing.
Thank you. And so certainly those who go in the person again, it's nice to get people around the table with us. And on that note, we move on to item 7, the future of primary care, and welcome Tracy and Emma to the meeting. It's always rules,
Thank you very much. It is very nice to be back in person. I was reflecting as I drove here. I think this is my first in-person meeting like this since pre-COVID. So yes, it is quite a change. So those of you who haven't met me before, my name is Tracy Jones, and I'm the Deputy Director of Partnerships. And I'm here today with my colleague who is...
Hi everyone, I'm Emma Fire, I'm the Associate Director of Primary Care.
And I'm going to be delivering for you 2 presentations. And the first presentation is going to be looking at the Fuller report, which is a national report that speaks to the future of primary care, not just here in Shropshire, but throughout the whole of the country. And that really is part of that commitment to keep the committee and members involved and aware of what the national direction of travel is giving for us. And then secondly, I'm going to give you an update on the constant engagement around the Shrewsbury Health and Wellbeing Hub. The person who normally leads on constant engagement, and I know you will have met at your previous main committee, is Edna, our Director of Constant Engagement. Unfortunately, Edna doesn't work on Mondays, so I have a presentation, I've had conversations with her, and Emma is the programme lead for the hub, so between us we hope that we'll be able to cover off and do justice to that constant engagement item. And just to be aware that Edna will be presenting on constant engagement later in the week at the Health and Wellbeing Board. I believe that's this Thursday. So I'm going to start off with discussing the Fuller report, and this presentation that I'm going to give to you is just a précis of the report. I asked for the full report to be shared with you as part of your papers, and I can see that has been done. If we can move to the next slide, please. So Fuller refers to Claire Fuller, who is both a GP and also Chief Officer of an ICB, so she has a dual role. And she was asked by Amanda Pritchard.
While we're doing that, Chairman, the main thing, as you remember, during ICS, ICB, and ICS, which are the 3, so it's not understood well by that committee, so I'm just wondering whether this committee understands it as well. So if you talk about the ICB, then what it is.
All right, so I'm very happy to give you a very, very quick definition of the ICB. So it stands for Integrated Care Board, and it's the organisation that has replaced what would have been Shropshire and Telford CCG.
Yeah.
So apologies for that. I know we've been using it, and I know some people refer to it as the ICS, which is actually the wider system.
The strategy.
Yes.
I think the point is that some of us have been involved in it, and some of us haven't.
Thank you very much. That's useful.
What's ICA? I know what ICA.
No, I haven't.
You've always been inventing, Kelly, you know.
We have got one. I don't know what it stands
You're
for.
trying to confuse me. You know.
You've got a hand up at the moment.
Thank you, Mr. Chairman. Can I ask for a brief definition of the integrated care partnership?
That's the key.
That's the key. So that is yes.
This is it. All right, I can hear
That's all right. Forward, and then you're sitting behind me. So the integrated care partnership will be, and that will be a separate board, and that is around the providers and the local authorities and Health Watch and other partners, where they develop the strategy that will deliver the strategy that the ICB is setting. So it's a separate organisation. There are presentations that we can share with all members that detail this. They're on our website, and we can also arrange for that to be shared separately if people want more information on that.
Yeah, just say as well, the briefings which you mentioned were set up last week, and I started to fill in diaries now. They will cover all that in detail, so it's nice to keep. So if you all attend, you all have all the knowledge that's needed.
So if I turn back to the Claire Fuller report. So the report has happened over, if we move on to the next slide. So the report was published in May, and it was a result of engagement with over 1,000 people, and they did the engagement through work streams, roundtables, one-to-one meetings, the ICB chairs, GPs. They had a dedicated engagement platform, and they also used Twitter as a means of communication. And it was talking about a consensus on what was working and what we can do differently, and I'll talk about the results in a moment. So just to really be clear on when they were doing this review of primary care, they weren't looking at the partnership model or the GP contract or funding formula. They were looking at what works well currently, what doesn't work well, and how we can integrate the whole of primary care, because quite often primary care is thought of only as general medical practice, i.e. the doctors in our surgeries, but primary care actually has a much wider definition in that it involves our community pharmacists, our community dentistry and optometry. Next slide, please. And as part of drawing this together, Claire Fuller has spoken about a vision for integrated primary care. And the things that she saw as key, and we'll talk a little bit more about them on the next slide, is that access, experience and outcome. And that really makes common sense to all of us, that it's about getting that access, what type of experience we had and what was the resultant outcome. And when they look at primary care, they're saying that we need to start thinking about primary care as having three elements of the types of interactions that we have. So a lot of people will be looking for help to stay well for longer. And that's about joined up prevention. And that's something that we here in Shropshire have as a basis of a lot of our programmes of work already. We then have, at the bottom box, we actually have people who may not use health services a lot, but they need to have access and advice when they do get ill. And we need to be looking at, Claire Fuller was right, that we need to be looking at offering more choice about how they access that and what's available to individuals in their communities. And then there's a third part of that vision that looks at people with much more complex needs. And those are not exclusively just multiple long-term conditions, those complex needs. When I've heard Claire Fuller speak, she speaks about people with mental health issues and saying these people need a much more proactive, personalised approach. And actually, when we move forward in primary care, and then the next slide talks to this, we need to look at how we are changing the offer, so the offer isn't the same for everyone, but tailored towards need. Moving to the next slide. I think really key message in the Fuller report that access and continuity are the biggest challenges, and those are challenges not only for our patients but also for our GPs and how they feel about their jobs and their roles. And there are 4 key areas that Claire Fuller has recommended to the government that we have as really key areas of intervention for the integrated care boards to be taken into consideration and moving forward. First one is about building integrated teams in every neighbourhood. The second is about improving same-day access for urgent care. Then talking about creating the national environment to support locally driven change. And then the fourth one talks about hardwiring the system to support that change. And I'll talk through them in the other slides in just a moment, but the hardwiring of the system, when I read the full report, I take this as the part that really talks to that delivery, because when we go through these things, and as you've read my papers that I shared with you, you would have thought all of this makes sense. We've heard about it, and I've heard it mentioned this morning in relation to something else, but how do we make sure that that change is supported? And I think what Claire Fuller's saying is we need to make sure it's actually built into the setup of the system. Can you move to the next slide? So the first part of the report talks about building integrated teams. And there are two really key shifts. And the first one is moving towards a much more psychosocial model of care. And by this means that actually all our health and well-being is much more than whether we have a defined disease or not. And not everything that affects how we are in our health and well-being needs a medical intervention to treat it. So the medical model is doctor diagnoses an illness, doctor makes you better. Psychosocial model of health and illness and care means that we've got to look at much broader factors that impact on our health. And this report is saying we really need to see much more of a move towards that broader model of health and care. And we need to be realigning our wider health and care system to a population-based approach. And I don't know how much committee have heard around the population health management approach and about the use of data. The report, the full report, really draws on that to say we need to understand our populations in terms of the services that we wrap around them. So the creation of integrated neighbourhood teams needs to evolve from the work that's already happened in the creation of the PCN, and the PCN stands for Primary Care Networks. And it needs to be more than just what we traditionally perceive as general practice. And again, just reinforces that point that we need to develop it from our understanding of population health, and we need to involve people and communities. And we talk about a strength-based approach, and this strength-based approach is actually fits hand in glove with your psychosocial model, because in a medical model, the doctor is the person who knows best, who has the power, who then tells you. In a psychosocial model, we're starting to understand that individuals know about themselves and their health, and that actually some of the support we get in terms of our health and well-being will come very much from the assets within our communities, that's people, and our own understanding and interpretation of health. The next slide, please. So the next point was looking at same-day access for urgent care. And the report talks about if we can get same-day access for urgent care correct and working better, we will actually start freeing up capacity for more personalised continuity of care for others. So urgent care is not to be mixed up or confused with the care that you get that's an accident and emergency. Urgent care is when you need to know an answer to something very, very quickly. You've got an issue, you need to know, you want to speak to somebody and find out about that thing. It's a rash, a symptom, a presentation. You need to know what it is. And that can be, and we need to start thinking, not just the GP gives us urgent same-day care. The thinking around online advice, self-care, what pharmacists can offer. It could be an appointment in a general practice, and that could be face-to-face, or it could be an online consultation. It could be visiting an urgent treatment centre, and it could be the 111. Now, we've got a lot of those components, little bits of the jigsaw already, but it's about how we work together to create that integrated pathway. One of the things that the report talks about is direct access to key diagnostics, and the report recognises that these are not always consistently available. And I know here in Shropshire that we hear that feedback about some of the services that we offer, they're not always consistently available. Next slide, please. And this just reinforces the concept that if you can get your same day third access right for urgent care, you'll actually start freeing up the time to actually allow for continuity of care. And the report goes to talk on that this is actually really in line with the delivery of something called Core 20+5, which is around health inequalities. Move to the next slide. Thank you. So the Core 20+5 is mentioned in the full report, but it's not actually drawn out. So I've just taken the liberty of sharing this slide with you for some extra information, because I wasn't aware of how much you would have heard about this, and it is a really key NHS policy that has come into being over the last 12 to 18 months. And it's starting to look at very explicitly how healthcare is going to address some of the known healthcare inequalities. And the Core 20 element refers to a population that live in the 20% most deprived, and that's nationally. So there is an index, and it's an index of multiple deprivation. So it looks at different factors and then gives each area of our the country a ranking. And those who live in areas of greatest moral deprivation, the most deprived, the most 20% deprived, we know from the data that we have, they have worse health outcomes than those living in areas of less deprivation. So,
Check your seat. I'm just going to make a comment to that, because I know we're doing some work around that, and the plus 5 bit, the sort of the local determination, we're very keen in Shropshire, particularly that looks at rural inequalities, because although we're talking about 20% most deprived areas by index of deprivation, obviously we recognise that's different within Shropshire and rural areas. So I just was going to mention, sorry, Jesse, you might be going to
the very next thing, that's perfectly fine, Rachel, thank you very much. And as Rachel mentioned, I've been working with Bernie Lee, and we are looking at that rurality as a potential plus factor, and working with some university academics to start looking at how can we start measuring that and understanding the impact of that, and also recognising other plus areas that we have in Shropshire, and how we might quantify what they are. So that's the 20, so that's the 20% most deprived, plus is areas of the Pacific, and we have got rurality is a very, very key one for Shropshire. We then have 5 clinical areas. So the clinical areas we look at are maternity and having continuity of care around maternity. For the second area is around those individuals with severe mental illness and ensuring they're having their physical health checks. And we know the real importance of that in terms of health outcomes. Then we look at chronic respiratory disease. We look at the COVID vaccination and making sure that those in groups that are at high risk of poorer outcomes are being targeted, and locally wonderful work has been done around that with the vaccination programme and continues. We then have the early cancer diagnosis, because we know outcomes are much better if cancer is diagnosed at the cancer diagnosis stage runs from 1 to 4. If you're diagnosed in stages 1 or 2, your outcomes are much better. And we're really looking to work, and we have several programmes of work which I won't speak to now, as I know I need to refocus back onto my full report, but just to say that there is a lot of work going on around early cancer diagnosis and this health inequalities work that committee may wish to hear about at a different time. And then The fourth area, the fifth area that we're looking at there is hypertension. That's high blood pressure and case finding working in the community. And certainly in terms of our the health checks for mental, severe mental illness, our chronic respiratory, our cancer and our hypertension, these are real areas that our GPs and other practitioners in primary care can be assisting us with. And the model that Fuller talks about just really makes sense in terms of this key policy. If we move to the next slide. So the next two things, of the four things that Fuller was looking at, is really trying to understand, well, we've got a model, we've got a vision, it's around integration, it's around much wider involvement in that same day urgent care, but we need to also understand some of the building blocks that are going to make this happen. How are we going to support change? And there were three key things that the report looks at. The first is looking at workforce, and there's something about recruitment. And when Claire Fuller came to speak to us, because we invited her to come and speak to our GPs and our community colleagues here locally, and the wonders of Teams and modern technology enabled us to do that and have quite a good attendance of that to discuss it. And one of the things that Claire Fuller was sharing with us is that actually we need to be mindful that some of the things that we hear about in the press, some of the way that GPs are being portrayed will affect recruitment. And she called this confronting the gap. She said, really looking at why is it that people aren't wanting to come into general practice anymore. She talked about retention, and that again is looking at the support people have, the environment they work in, and she talked about the parity and connectivity with the wider system. And by this she meant that when the general practice is commissioned by the NHS, but as individuals, they are individual businesses. Within the wider NHS, we have things like staff surveys, a national staff survey, we have different access to health and wellbeing resources. And what Claire Fuller was saying was really look at how you connect those into your primary care, your general practice staff. She talked about estates, and I know we're going to talk a little bit in a moment about the Shrewsbury Health and Wellbeing Hub. And she's it's an interesting conversation because what she's saying to move away from a traditional model of primary care, and she saw estates not as a barrier, but actually as a catalyst. So as we move to different types of estate, it actually provides us with an opportunity to integrate. And she also talked about when we're thinking about estate for primary care, we need to think about connecting with local authorities in a way that hasn't happened in the past. And of course, when Claire's talking about it, she's talking about it across England. And then data. And one of the things that they found over the COVID period is that having access to data, having the ability to understand where different population groups are within a geographical area has really changed the way in which services have been presented to that group. Now, as somebody who's not involved in the day-to-day work, you might think, well, surely GPs know all of that data. But actually, COVID has given us a whole new set of data that we wouldn't have had before, and that people who aren't working day in, day out in the NHS would just naturally presume that people had, but they didn't. Next slide, please.
Sorry, bear with me. Is that the one?
Yes, it is, thank you. And then the fourth thing was about hotwiring the system. So this is about looking at the role the national government can play, what they what they're doing in terms of their policies, and what they're telling us as newly formed ICBs and NHSE policy, operational planning guidance. Organisations and integrated care systems, how we all have a part to play in ensuring that we're creating the right environment that supports the changes to deliver the vision. So the vision being those three key areas of intervention in terms of primary care, and it builds on all of the other things that are in the report that we've spoken to. So it talks about the data digital, the estates, the workforce, talks about looking at access, talks about backing the existing practices in terms of some practices, the existing way of primary care delivery is working well for them, but also to look at new models of care. And there are some quite radical suggestions just at the end of the fuller document. Only references some things that have happened in terms of vertical integration not too far from us in Wolverhampton. And then looking at locally led investment and support, and really embedding the primary care leadership throughout the system, thinking that we've moved from clinical commissioning groups that were led, GP clinically led, into a system that's perhaps a little broader, and thinking that we need to make sure we have that primary care leadership, and we do have two primary care voices within our ICB board. If we look at the structure of the ICB, they're looking at gaining clinical input throughout a whole manner of ways. It's not just individuals who sit on boards, because that isn't about that influence at the top level of the board. But when we think about ensuring that we have that connectivity of our primary care leadership throughout our projects and our work, and it's looking at how we enable primary care at the system level and starting to have those conversations. Next slide, please. So in terms of nationally, so this is Professor Martin Marshall, he's the chair of the Royal College of GPs. They recognise that, as does the report, that if we're going to deliver on the vision, we need to look at our general practice workforce. We need to continue with the progress of expanding the general practice workforce, looking at the resources that we are giving to our GPs and their colleagues and their teams in terms of premises, looking at digital enablement, and just looking at one of the things he calls out is the space to accommodate the expanding workforce and diagnostics in the community. And they're really pleased about the flexibility. So the ARS stands for Additional Role Reimbursement Scheme, and this is really recognising that there has been a lot of investment over the last 18 to 24 months in roles that support primary care. So that's greater investment in roles around physicians associates, physiotherapy, doing the sort of the first contact physio, social prescribing. So those are all new roles that are being funded and embedded within primary care. I was going to say next slide and then realised that.
I'm just dealing with an echo issue, but I think that's probably sorted it now.
Apologies for everyone. And then locally, Simon Whitehouse, who is our Chief Executive Officer of our Integrated Care Board, he was part of the group that looked at preparing the fuller report. He also signed a letter of support to government alongside with all of the other Integrated Care Board chairs to say that they supported what was within it. And what will happen is the government will review Claire Fuller's report and then respond. As I've mentioned, we arranged for Claire to come and talk to us so we could have that conversation locally. And the outcome of that meeting was that actually we're not going to wait for top-down information to say do this and do that. We're actually going to start thinking about what we already have in place, what do we have to put more in place to start moving towards this vision. And Claire Parker, who is the Director of Partnerships, has taken the task that for September's Integrated Care Board, she will bring a plan, a report that starts talking about what our local implementation plans will look like and how we can build on what we're already doing around integration, new models of care and population health working, partnership with our public health colleagues, and also the work we're doing around addressing health inequalities. So it's just to say, locally, we've spoken with Claire Fuller and Simon's committed as via Claire Parker to bring this report to the September Integrated Care Board to start thinking about, well, what does this mean for us here in Shropshire, telling them everything. And I believe that's the last slide.
Thank you. A lot of information there to take in, but also it's been circulated, so we've all to digest it more thoroughly. I can see that Heather has been writing a lot there during the presentation, so let's over here. Lots of questions.
Thank you. I think this is eminently sensible. I think it could be amplified. I think it actually delivered be one. What I will say for Shropshire, that unless actually those of us on the ground are involved in any system that's brought forward to deliver this, it will fail. One of the big issues that I've raised time and time again is there are areas of Shropshire that have very poor access to anything now. It's not about joining up pharmacy, dentistry, mental health GPs. We'd like dentistry to work. We'd like mental health issues to be dealt with, because they're not. And just joining all of that up is an absolute mess. And if you're in the rural area, you're, to put it colloquially, stuffed. Pharmacies are few and far between. And actually, most of us get our drugs from the local doctors, because that's the only pharmacy that you will go to. My nearest pharmacy itself is 8 miles away in 2 directions. There is no bus service for either of those. The southwest has 1 pharmacy. When you talk about neighbourhoods, there's the rub, because what normally happens is Shropshire decides that a neighbourhood includes Ludlow for us in the southwest or Craven Arms, neither of which are accessible. Actually, we ought to be looking at Plum and Bishop's Castle, and then looking at the access issues for those, because there is absolutely no public transport either. Access to Shrewsbury is intermittent, and some areas it doesn't exist at all. In fact, most areas it doesn't exist at all. And then you begin to look at digital. Well, yes, we're going to be improving it, but actually we've got mobile not spots, we've got areas where the broadband is still terrible. We have, and I did all that to council on Thursday, actually we're not delivering, and actually if we want to deliver any of this in social care or health, we actually do need proper coverage and proper training, because there are many people who can't use a computer or a smartphone and don't have access to a smartphone. All of those things will completely scupper any of this in Shropshire unless you deal with the basis of all of it. I would like to see a timeline for the delivery. I would want to see where you're going to get the resources from to make sure that access is allowed. It's eminently sensible that you have pharmacy, dentistry, GPs, mental health all working together. How you get that across many areas of Shropshire is going to be interesting. And furthermore, you will have to work cross-border with Wales, with Powys, the Powys Teaching Health Board and so on, if you're going to deliver it for many chunks of Shropshire. And then unless you have that good joint working, there won't be a solution to it, because none of that is joined up now. So I look forward to a timeline for resources, because it will take resources, because we just don't have them at the present time. And all the rest of the planning, and please involve local members in this stuff, Because if you think we're all going to access Ludlow or Shrewsbury or any of this, you're wrong. It won't happen, and we go backwards and we become a third world. You have to put down some guidelines for the future, and then we get what we want.
Thank you, Chair. I think this is an advisory report. This isn't an official report.
Yeah, I think the purpose of the report is just to share with you the direction of national travel, because obviously we do want to be given a commitment that will involve you in the development of primary care and services going forward. So this is just really start that, so that when we have further conversations, you've had the background information rather than us coming to a future and saying, well, that's Fuller said, blah, 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 no one's going, but who's Fuller and what did she say? Why did she say it? So yes, it's part of that way of working that enables us to give you the first, this is what has happened in this report. We all agree that there's good things. I've taken some notes, and I think Heather's points I've summed up in my notes is you need services to join up, don't join up more stuff that doesn't work. It's my reflection of Heather's comments.
Because there is behind this a bit of a kind of tussle going on, isn't there? The BMA have voted, I think, in the last couple of weeks to withdraw from primary care networks, and I think that's because, in part, there hasn't been. I don't think there's a kind of. I think people are very. Primary care has been very keen to look at building multidisciplinary teams, but they haven't had the resources to actually supervise and develop the team. So, as I understand it from surveys, what GPs have been saying is that they found it kind of more work with very little, advantages for them. And so you've got the BMA potentially pulling out primary care networks, and I'd just be interested in your views on that. But also, I was really interested in the Fuller report. Lots of really good suggestions in there. Lots of really interesting stuff. And the digital side of things is interesting, but very complicated, isn't it? Because I think there's the stuff around building these teams that can put people at the right place at the right time. You know, if someone phones up, they need an urgent answer, but they don't necessarily need to go to A&E. The first point of contact doesn't necessarily have that information. So, on the one hand, it would be really good to almost have a dashboard that you could direct people to. Is A&E really busy at the moment? Could we, is there somewhere else they could go to? But there are massive issues in both the computer systems to do that, and also the sharing of information. So I guess there's two questions there. One is, how are you going to overcome the BMA's I suppose rejection of primary care networks, and how is the digital question going to be answered locally?
So, answer the first one around the BMA. Obviously, they've taken that vote. We haven't had any discussion around that locally. None of our PCNs have come forward in terms of. So, I think yes, we've had that discussion. Whether what will happen nationally with that, I think we'll have to have a watching brief on. So in terms of the second question around digital, you're absolutely correct. So there's something about having the correct software, and then there's enabling the sharing and joining up of data sets, which, as I spoke to, and it's good you recognise that tension in having access to different elements of data. Work is continuing with the electronic single record, and there has been data sharing agreements in place that enabled us to deliver care over the COVID period. So what Fuller is saying to the government is, think about, yes, we must protect people's data and we must have due regard to their privacy, but at the same time we must look at how does sharing data provide real benefit for the services. We've got several issues, and we recognise them when we look at our health inequalities agenda, because we have got the actual infrastructure and Councillor Kidd recognise that not all areas have access to reliable Wi-Fi and broadband and ways of accessing the internet. So there's something around that. There's something around the actual ability to afford devices to use it. So I'm from a patient perspective. And then there's something around training, and that training and understanding of devices will include both staff and patients. So there's a programme of work that will obviously need to accompany that. We can't just expect digital to transform without any structure or planned work around it. Absolutely.
Thanks. And on the infrastructure behind the PCNs, because I suppose at the heart of this is a sort of tussle for money, isn't it? Because the money's being channelled through the PCNs now, which are kind of strange organisations without necessarily having leaders. So that's kind of good. Anyway, so the money's being channelled through the PCNs, but certainly I think for a lot of people in the primary care, the LCGP has released their own document for the future of how to organise primary care, and they're asking for the money to go through the GP contract. So there are different models, and so I suppose there's just one thing which is, it's interesting that you're, as an ICS, are endorsing this advisory report, which is what you're doing. Okay. But as an ICS, are you going to provide the infrastructure to run these PCNs as they continue? Because I think that's been the big issue, is that practices just aren't able to, they're getting all this money for new staff, but they're not actually able to supervise them, train them, and it's dragging them away from their core business.
I think the issue of PCNs and how they're running, we could spend considerable time discussing. So each health PCNs will mention that they don't have leaders, just to mention that they all have clinical directors. And also we have our training hub, who are supporting some of these the new roles that are coming through the R's. We're actually looking at locally. I mean, nationally the picture is varied and different, and it will be varied in terms of infrastructure to weekend. But locally we are supporting facilitators that assist in supporting some of the new roles. Does anything else you'd like to
Can
we all go out to the corridor and do the meeting out there, because actually I can't stay, it's too hot, there's a health issue.
we ask people to be quiet then?
Sorry, I just wanted to add to that in terms of we recognise that the PCNs, we've got 8 PCNs across the batch, 4 in Shropshire, 4 in Hertford, and they're all at different stages of maturity, and they're different sizes and different demographies and needs and have you their population. That their development is an entity, because as you say, they're not really an organisation in their own right, they're an entity, a network, which is not the same thing. And that's been hindered, their development's been hindered to a degree by the COVID, because their focus has been primarily on the vaccination programme and getting themselves established. We've recognised that. What we've done is we're doing a piece of work with each of the PCNs to identify what their organisational development needs are over the next 3 months. And from that, we will then be coming up with a PCN development plan, and we will support them and help them to support themselves. So we have recognised that, and I hope that's helpful.
Yes, I wanted it. This is going.
I know you want to family.
Cheryl,
I think the report
That shows up on the
I think the report section, we really obviously need to know more. It's a good start for what we want to do. There's a couple of things I just want to mention. I just wonder how many people who need medical attention know the difference between A&E and urgent care, and perhaps we should be educating them there. And if they've got a problem, rather than just ring somebody or attend to A&E, perhaps they should get some kind of first point of contact, not to get mixed up with our first point of contact here, but a kind of first point of contact so they know where to start. And then the other one is, of course, the old test that we need a lot of pseudonyms like ARS. That was pointed out to us today what it stood for. There's a lot of words coming in there that I don't understand. Is it possible at the end of each report, such as this, that we can have an explanation of what that means?
Yeah, we can sort those.
So, just in response to that, just to say that one of the things that 111 could be doing in the pathway is actually being that point when people don't know who to call. The process of having 111 is to assist and help us. The second point around the acronyms within this report, if you're referring to this, Gerald, I didn't like this report. But I'm very happy to take away the idea, the concept that any reports that are written have that glossary page, because we do recognise that there are so many words and terminologies that we use day in, day out. And actually, I thought I'd avoided them in my slides, and I realised I hadn't. So I'm at fault there.
It wasn't into your report, it was your report sent to this committee. They quite often have a lot of acronyms there. And we have to find out what they are.
We can look at that, James. Tracy.
Thank you, Chair. Oh, it's not working, is it? Did you say? Not working. I welcome this. It's absolutely holistic approaches. I'm a nurse at GP practice in Ludlow, so it's great. We actually are doing a lot of this work already, sort of respiratory, mental health, got the front line, post-protocol physios, etc., etc. But we have lack of space, and this is a key issue. We also have lack of staff. And we struggle to recruit nurses. Nurses are leaving quicker than they're actually coming back into the practice. So my thought was around our community hospitals have loads of space under community hospital. Is there any way we can harness it, use that space to complement using the space of GP practices? Because we have loads and loads of empty room. I think our community hospitals are at risk, and this would perhaps ensure the future of Ludlow Hospital, Bishop's Castle, and I know Temporary Hospital. I went to a meeting on Temporary Hospital a couple of weeks ago, and this is something they're looking at, where their GPs will some of the things they can provide will be provided from the local community hospital to try and increase the use of space there. Another thing I just want to echo: pharmacists. Every day I go into the pharmacy, they are using locum pharmacists, they have job adverts, they are leaving quicker than they can't recruit, and that is because they are struggling with the locum pharmacist. Sometimes prescriptions are taking 7 to 10 days. I have patients for urgent antibiotics that wait 7 days for an antibiotic. So to say you're going to use your pharmacist as for information and support to people who need urgent care, I think that's going to be a massive task to try and get them to provide that, because they cannot provide basics at the moment. It's a real issue. It's a real issue for GPs when patients are waiting for drugs for 7 to 10 days, and these are not drugs that they can wait 7 to 10 days, or these are urgent. So that's just another issue. But I would like to see the involvement and some talks with our local hospitals to see if we can use that space, because this Ludlow Hospital has 37 beds at the moment used. There's 2 empty wards, and most of the clinic rooms are not used. And just one brief thing, because this is real bugbear. There's one part of this where it's already failing. As at a weekend, patients who are needing, this is probably not your, but it needs looking at, patients that need dressing changes now have to go to Shrewsbury. So I have a patient at the weekend, an elderly patient with a wound on a leg ulcer. They have to go to Shrewsbury to have a dressing change, to then sit in a queue for 5 hours. Now, if that's an holistic approach, saying we're going to provide you with a dressing change for the weekend, but your district nurse won't come and do it because they've been told they can't do it, because if that person's mobile, they have to go to Shrewsbury. Now, that is not working. This echoes what Heather said. We cannot have patients from the southwest, hence Ludlow, going to Shrewsbury for a dressing change at the weekend. So there's so many little things that need to come together. I really welcome what this is absolutely brilliant. but I can see failings already if we don't have more cohesion. And you know, we've got to understand the Southwest transport, no transport, so difficult. So having patients paying £50 for a round trip to get dressing changes, and we can't see. I don't want patients to have to go to Shrewsbury for other things. That's basically what I'm saying.
So we're looking supportive of the principles of the national report, but really having due regard to local circumstances, really, isn't it, what you're saying, Tracy?
Yes, absolutely. Just think about distances, things, and look at the community hospitals.
As you know, Health Watch is a voice of the people. I tried to read this report, the full report, a lot of good things in it, but I was beginning to lose the will to live after a while because it was so flaming long. And I'm just wondering how robust and consultative you will be, you know, more public. They will be completely beyond their ken, most of this. I know you're going to do a lot of it top down rather than top up, rather than down up. But you've got to make sure people know what it's all about. And I don't honestly think they would have got great sympathy for what Heather says. I've got similar problems. I mean, I'm getting on a bit, and I have very good knowledge of IT. My daughter, for instance, I've got to be careful what I say, but she's terrible with IT and computers, but pretty good with paperwork, and that's me. I haven't got one of those darn things to do. So I'd like to know exactly how you're going to involve the public and people, because we get information back and we can possibly ask people certain things for Health Watch, but we need to know they are involved. You mentioned about, you know, let us hear, you're a committee now. I would like to think you go down to the grassroots and ask parish councils as well what they think, because they're there, they see the people on the hand in their local areas, and you never seem to mention them. They're very important. I've been a parish councillor up until recently for nearly 40 years, so I think I know a little bit about what they do. Thank you.
Right, I've got Heather, Gerald, Roy, and Ben's at the back, and then there's Ryan and Rick, as time get away from us. So Heather, very quick point, because you've had a long say.
As I say, I liked the report. It is holistic. It could be magma, could an apple pie. I will repeat that because it could be. What I think I was distressed about when I read the report was all of the examples are the Wirral, Surrey, Westminster. And actually, we need to be looking at these things in Northumberland and Cumbria. We do need to be looking at our community hospitals. We do need to be looking at innovation. And as I said at Joint HOSC, when we're workforce planning, which is one of the things you are meant to be doing, or the ICB are meant to be doing at the present time, actually, if you can attract people here because we're doing something a bit different to deliver for our communities, then people will come, despite some of the background noise that goes on about working in the health service in Shropshire, which isn't great. So we need to be forging ahead with this, and really it isn't about this committee. David's right, it is about the local members on the ground and the parish councils on the ground. My parish councils have real views about this. So I wanted to deliver, because if we don't get this right, we will be second and third world. And I've told Patricia Davies this about Bishop's Castle Hospital. So work with Patricia Davies with the community health hospitals, because they are the answer. At this rate, we look as if we're just selling them off. Although the lease on Bishop's Castle Hospital is very long, I might tell you. There we go.
Gerald.
Yeah. Just one thing I'd like to say that obviously they do have to get down south with transport. We have difficulty in the North Shropshire transport. Places like Wickstall, they get one bus in and they get it on a Friday. That's the only transport they get into, which is they've got to combine the shopping and a visit to the doctor with all that. So transport isn't just about North South Shropshire, it's about all of Shropshire or part of Shropshire. North, South, wherever it is, it needs looking at, and not just South of Shropshire.
Good point, Gerald. I was going to make exactly the same point. Right.
Yeah, I mean, it's a good report, no doubt. It's got some good grounding in it, and it reminds me very much of the kind of data that was included in the Black Report back in the 60s and 70s. The one thing I worry about, there's an awful lot of circles of communication here. And if we take, for example, consultation as a major one, I recently had a practice manager come to me, having had a letter from a member of the public, a member of the surgery, saying a certain service would be withdrawn because they were going to have to base it at Telford or Shrewsbury. This was always covered by a mobile bus that used to come to the surgery. So it meant at Bridgenorth and Market Drake, we had to start finding ways of getting to whichever hospital. There is no bus service to Telford Hospital, which would have meant 100,000 miles of extra travelling for patients and training. Now, that may have been sorted out, but it was a classic example of somebody telling a patient, this is stopping, but not telling the surgery, the local council, or the county council that this was happening. And okay, it might have been a mistake on somebody's part, but it's one of those things that was a major issue and it shouldn't have happened. And I just want to make sure that at the bottom of everybody's list is consultation, consultation, consultation. Even if it does take a bit longer to get things done, everybody should know what's going on and how it affects them. Thank you, Chair. Thank you.
Really? Finger off, Bernie. Too loud.
Thank you, Mr. Chairman. Bernie Bentinck-Meal. The full report appears to have been based on an information technology platform of 1,000 people and will influence healthcare for 60 million people in the UK and almost 500 million in Shropshire. And so I would question whether this is actually representative of the groups who will use the service. My colleagues have already identified consultation issues, and this consultation did not involve the majority of people who don't have information technology access and who most use the NHS. And so how can this report represent healthcare for that group when they go to consult? The second is 2/3 of people in England and in Shropshire are overweight and 1/3 are obese. This is associated with dramatic increases in poor health outcomes, including premature death. Why wasn't this one of the 5 core issues that were going to be examined, and will it be examined? With regard to the BMA, general practitioners are completely overwhelmed in the UK in general and in Shropshire. The government promised 6,500 new GPs by 2024. There are 1,500 less. What is the ICB going to do to redress this problem? And it's not from pharmacies or other allied professionals, because GPs are the primary diagnostic tools that we have at our disposal. When you go to a GP, he or she tells you whether your symptoms are significant or not. As a patient, how can I or anybody know whether our symptoms are significant? We require health professionals to be able to determine it. And because GPs are overwhelmed, they're not able to meet the need. Indeed, the Royal College of General Practitioners has said that 20 minutes should be standard for a routine appointment in general practice. It's currently 10 minutes. What is the Integrated Care Board and the system and the partnership going to do to address this problem, which is overwhelming GPs, and they're not being paid any extra money to provide additional resources? I know GPs who are working late in the night because they are not paid for the work that they're doing, and they can't afford to hire people to come and do that work, even if they were available. With regard to access to GP, I have tried to access a GP surgery for over an hour on the telephone without success. What is the integrated care system going to do about access? There are no appointments, routine appointments for over a month. And how do people know whether their symptoms are urgent or not as a patient? Finally, in relation to accountability, the Integrated Care Board, I understand, has some statutory powers which enable it to make changes to policy without referring to the Minister or the Department of Health. What is the ICB, the Integrated Care Board, going to do to ensure it is accountable to the local population? Thank you.
Obviously, there was a lot of questions there directed towards our Integrated Care Board, and it may be that obviously we are taking minutes of today's meeting, and it may be appropriate that we feed those into the Integrated Care Board as a question, as opposed to the presentation that relates to the Fuller report. In terms of the first question around the level of engagement, it is just to note that the Fuller report was a national report, and the purpose of bringing it here today is to provide the background information. People will have opinions on whether it was inclusive enough in its range and reach. However, that isn't something that I'm able to give a comment on at this meeting.
Mr. Bentic, I think if you feed those into the manager, we'll pass those up through chain and get some answers for you.
Thank you, Mr. Chair. I think there are some other questions that have been raised from the board as well. So some of those things, like the rural
They just go to the right place. This is about the full report.
No, I understand that, but some of these things that have been raised by the committee today also need to go to the primary care board. That was my point. So if that can be fed through.
Okay, thank you. I think we've got some technical issues going on. Are they still going on Monday?
I was going to say, Chair,
It would be possible to
have a very brief break so we could sort those. That would be very good.
10-minute recess, then we'll come back and allow them to cool down a bit.
It's the fans wonderful.
So we'll come back with that. Half 11.
Yeah.
My broom's full right now. It's definitely better. I've just seen it. Really, I don't want to actually.
Bruce was there, that's been federal. Oh, no, you can't just- So we were like years ago before the COVID, we would have a check. You know what I mean?
No, I don't.
Thank you, Chair. I confirm we're now restreaming.
Thank you, Amanda. Thank you, members, for your patience while we got the IT sorted. Hopefully, we're now in less actively now. So we'll carry on with the agenda. Item 8, it's Groundhog Day, so we're over to Tracy and Emma for an update on the shooting health and wellbeing.
Thank you. So as I said earlier in the meeting, I'm delivering this presentation on behalf of Edna, who is our Director of Comms and Engagement. So I know that you had a presentation from both Edna and Claire at your May meeting, and there was a request for this meeting for me to share with you the timelines around engagement and the general direction of travel and the engagement activities that were planned or are being planned. In terms of the paper in your pack, I supplied much more than just the engagement, and that was really because I wanted to ensure that if there were members who hadn't been involved previously, that you got some of that background information. So I'm going to just focus in on the engagement and the comms and updating from when you had your last update in May. So this slide just gives a background to start talking about the first elements of the communication and engagement around the Shrewsbury Health and Wellbeing Hub. Started back in early 2021, and that was followed by a phase of engagement, a listening exercise over the summer of that month, and then looking at how a patient and public advisory group was set up, and then we go to the end of winter 21-22 and the start of the development of the case for change. And then in May, there was a second phase of engagement, which was the focus groups, and they were looking at discussing that case for change. So if we move to the next. So one of the things that we were asked to share with you as a committee was a timeline and a roadmap of where we're going to, and this slide gives that in a pictorial form. I can see that we've got down this meeting here in the July, but what isn't there is the Health and Wellbeing Board, and this discussion is happening at the Health and Wellbeing Board on Thursday, so that should also be a reference to Health and Wellbeing Board in that top line that talks of which governance meetings. So in terms of the acronyms, you've got an AIC there in April, that's your Assuring Involvement Committee, that's a committee of the clinical commissioning groups, which is constituted of members of the public representing different aspects of patient groups and individual members of the public, and that's sat within our clinical commissioning governance, and they receive reports on comms and engagements of activities of the NCCG. And then you can see the other groups. There we've got PCC, which is our Primary Care Commissioning Committee, and then you've got HOSC here. Well, it's actually, and I do get your acronym for this particular meeting mixed up, but I'm just going to call it the Shropshire HOSC as or HASC as a shortened version. And then we're here again today. As I said, there'll be another governance meeting for open discussion around what's happening, and that's on Thursday. And then there is a commitment to come back to this group again in September, ahead of us actually going out into the next formal phase. So you can see the next line down talks about how the comms and engagement, the different elements have been happening. So we start off with developing the case for change and the vision. We then had a period of engagement with stakeholders, and then we talk about the options appraisal, and I'll talk a little bit more about that as we go through the slides. And then you can quite clearly see there is the commitment to consult the public, and then a period of time whilst those that information that's been gained will be appraised, and then there will be a publishing of the outputs of that constant engagement. We also wanted to just, and I think this was also part of your request, was to share some of the timelines around what we call the technical elements of the programme and the build element. So in terms of the programme, you'll see a star there with the letters on IIA. That's an integrated impact assessment, and that just doesn't happen once in a process. It's an iterative process where it will be built on and developed, and different aspects of looking at what forms that integrated impact assessment will be brought into play. An example of which is that the initial feedback spoke very much around travel. So our integrated impact assessment will have within it those implications and a much deeper focus on travel, and that's why it's not just done once and then put on the shelf. It's actually done as the process develops, and that's why we've got several integrated impact stars. We then have the in the purple, I want a chevron. We have the pre-consultation business case. That's what PCBC stands for, which is the business case that will be consulted on. And then you can see that as part of the programme work, we analyse the results of the public consultation, and then you can see that going forward to developing and the business case. And then underneath you can see how that fits into the timelines that we would be working to in terms of the actual build. OBC stands for Outline Business Case, and that just shows how what we're doing around developing the content engagement fits in with how we're looking at the programme of work and how that then reflects the timeline for the build, and that gives an indication of that timeline within the programme that you are asking for. So I hope that meets broadly those that request in terms of timelines. If we move to the next slide. So this just really goes over that first listening exercise that took place in August and September, and I know that both Claire and Edna spoke about this at your meeting in May, and that there are sections and groups of people who really felt that they weren't spoken to and weren't involved, and I know that's been acknowledged and listened to by Edna and those who are leading on the content engagement. But that just gives you a flavour of the people who did respond, the 1,287 responses, the things that people were saying that were important to them in the model, because the listening exercise was talking about, if we had a hub, what sorts of things are important to you, and those are the things that were fed back. We move to the next slide. This is talking about, and I think this is something that was mentioned again in your main meeting, was the stakeholder reference group. And that's really understanding how they're going to develop and determine evaluation criteria when options are being considered. And it's also going to be the steering group for the content engagement activity, because what's really important is that that content engagement, it isn't a secretive thing. It's really wanting to be open and bringing people into the content engagement, and using the steering group approach tries to do that by not just having defined members there, but actually, when I say defined members, thinking around just NHS people, it's that much wider. And so therefore you can see the representation that we're looking at that steering group, which is your Health Watch. PPG stands for patient participation groups, local authority, elected members, representatives from practices, key voluntary sector organisations, and other equality groups and those who may be more impacted on by the plans. And there are some dedicated focus group sessions that are being arranged, and I know if people haven't been told of them, I have the times and dates and provide those details to people, and they're next week, Tuesday 26th and 27th, and I believe that's being communicated out to council members. Next slide, please.
We could school holidays.
So in terms of addressing inequalities, when the work began, an equality impact assessment was completed, which would give a very high level indication of any potential disproportionate impact. And the equality impact assessment looks at your 9 protected characteristics, and that's why it's important to feed that into an integrated impact assessment, which looks at much broader factors like transport, for example, and details of the other services that are being proposed. And there's a commitment there that, as well as some of the key voluntary and charity organisations, they're looking to engage with the seldom heard groups as well. So it's proactive reaching out to those groups, so it isn't just people who would normally reply to standard questionnaires. We move to the next slide. So over the period of May, and I think these would have been happening in between when you last had the presentation from Edna and Claire, there's been 6 focus groups. That was a mixed format, 4 online and 2 face-to-face. And the slide there describes how people were asked around their experience of general practice, what they thought about the aims and benefits of the hub, what they'd like to see in the hub, and whether there was anything else that the programme team should be considering. And they shared at the focus groups the essential criteria and also the desirable criteria to look at what people were starting to identify as being important in relation to the hub. We move to the next slide. So this slide and the next slide detail the essential and desirable criteria that will be used as part of the evaluation process. So if we move through to the next slide. So the first one was this is the essential, and it breaks it down into some of the questions that will be asked when they're looking at the different models and delivery within the hub. And the next slide, please. And then this is the desirables. And these desirables were drawn from that listening exercise. And I think when you look through both the previous slide and this slide, they are all things that we would think about, well, if we're asked as individuals around this table, these would be the things that we would also be identifying. Different things will matter differently to people. One of the things that quite often comes up is when we talk about travel, some people prefer to have primary care closer to their place of work. Some people think about it, well, how far is away from my home? So different things will matter differently to individuals. But collectively, there'll be some things there that all of us would want in terms of the ease of booking appointments and the availability to have different types of appointments. We move on to the next. So what's been drawn out of those focus group discussions, and these are the key findings from the focus group discussions that have happened over May. That the travel impact has been identified as something that's really important and valid to a great deal of people who have fed back. People have talked about public transport as well as private transport. So they've spoken about traffic issues, and they've spoken about how some of these issues around travel could have a differential impact on older people and also for people with disabilities. Many people said they couldn't argue with the case for change as presented because it was talking about more joined up thinking, it made sense, and really change needs to happen in the way services are provided, in very much the way that we have spoken this morning about the Fuller report, that in essence there is a strong case for how for joining up services. Also reflected from those focus groups was fear or an uncertainty is felt by people, because this is, you know, people see this as change, and it is change, and there needs to be discussion around those benefits and what services are going to be provided. And some residents have expressed their concerns about losing their relationship with their GP, their continuity of care, and that this new model of the health and wellbeing hub could lead them to receive an impersonal experience. If we move to the next slide. So to conclude the second phase of engagement, so we've had those focus groups, the 4 online, the 2 face-to-face. There's now going to be some additional focus groups of those who are the more seldom heard, or those groups who aren't necessarily putting themselves forward to come to work with us, and also and the commitment to work with local councillors, and those are in progress. And as I mentioned earlier, and I think has been mentioned earlier in the meeting, there next week. There'll be a stakeholder reference group established, and we spoke about what the membership of that was going to be in terms of that broad, wider membership. And once that initial meeting for the reference group has been set up, then that group will hear the focus group sessions. We'll be able to hear the complete focus group feedback, because that will coincide with those other focus groups having happened. And the other thing that Edna wanted to share was that a leaflet for practices is being developed, which will help aid patient engagement and outline why practices are being part of the programme, and talk about some of the factors that have contributed to that case for change. But rather than just being in the case for change document, which is readily available on the website, and we recognise that not everybody goes to the website, this is Edna's commitment to ensure that patients are having that level of information and knowledge imparted, and obviously signposted if they want to get more information. Next slide, please. So there'll be a combination of scenarios, and you've seen that in the slides that preceded the comms engagement slide in this pack, which talks about looking at which combination of services may form part of the hub, and then there'll be a scoring of the different options, and that will be undertaken by that wider reference group based on the communication and engagement that have informed the desirable and essential criteria. The integrated impact assessment, as I said at the beginning, has to be built on. So yes, there is an initial equality impact assessment, and that initial equality impact assessment identified that age and disability could be disproportionately impacted on and needed to be considered as part of a wider impact assessment. It also identified that we needed to give due regard and think around travel and what did that mean, and that will form part of that ongoing integrated impact assessment. When that has this phase of engagement comes to a close, a report of all of those findings will be compiled, and then it will be shared publicly. And as the timeline from the slides back shows, we'll be coming back to governance and committees to actually share that before the consultation starts. We're looking that it's likely to run between 8 to 12 weeks, and looking at that starting approximately between October and December. Is there a next slide? No. So that's just sharing back that update that the focus groups have happened, or virtually 2 face-to-face, and how that's starting to feed in, and the subsequent comms and engagement.
Yeah, thank you, Tracy. The only question was at the end there, whether we can come back to us, so that's that's great news. Kate, you're first out of the box.
Thanks, yeah, Kate Halliday, Bellevue, Shrewsbury. So there are 2 GP surgeries affected in my area who would potentially move to this new hub if it goes ahead. It's creating real upsets, I'm sure you're aware, for people in terms of worrying about travel, worrying about losing regular contact with their GP and primary care staff, and it's a really big issue. It's the biggest issue I've come across since being a counsellor in terms of creating upset and concern. And I guess my concern about this is that this has been presented to us as the only option, and you're saying very clearly in this report we think this is the best way forward. But I'm just wondering, have you looked at any other ways? I mean, that the Fuller report is full of some really interesting ideas. It talks about having a joint approach to estates across health and social care. I mean, I think Councillor Huff's suggestion earlier was an excellent one, an excellent example. Perhaps looking not simply at primary care, but hospital secondary care estates as well. And certainly one of the examples of good practice in the Fuller report was, I think it was Dorset, have done a sort of stock take of their estates and have begun to look at that. And what this feels like is that NHS England has come along and kind of said, oh, there's a pot of money here, and people have been excited. I'm not against investment in Shrewsbury, I'm all for it. But there are a number of really big issues with this. I think that people, basically the travel issue, I've been trying to get to the bottom of this, and I noticed that the ICS board, there seemed to be an indication that Shropshire Council were going to start supplying new bus routes directly to this surgery. Now, that is a massive cost. I'm not sure whether the question I saw was, is that Shropshire Council's understanding of the situation, and I haven't got an answer back from that. But putting on a new bus route is an enormous cost, and I'm sure there are many people sitting in this room who would like their residents to have better bus routes around the country, around the county. I think also it kind of clashes head on with a lot of the council's desires to look at climate emergency, reducing travel. This is going to be thousands of extra car journeys and bus journeys on our roads. And I mean, I know, again, if you ask a councillor what some of their biggest inbox issues are about, it's about congestion, difficult driving conditions, dangerous driving conditions. And, if it is seated in Meal, there are 2 large secondary schools. There's just so many issues about transport for this. Given that, as I understand it, the advantage of this is to get a large new building. So there's not going to be an investment in the primary care workforce. And I suspect what you're going to say is we want to build these multidisciplinary teams, and I do too. But the Fuller report is full of examples of how they have done that without having a massive, it's a mini hospital. I mean, this is actually, we are being asked to take part in a massive experiment. We don't know whether this is going to work. It's going to be an enormous building. It's, I'm just wondering whether this is going to work, basically. I think that there are also lots of issues around the wider determinants of health. We know that only 10% of health inequalities come from one-to-one appointments or, appointments with health practitioners. This is going to stop people walking, probably cycling, etc. It's going to be putting more carbon into the atmosphere. So I guess my main question is, there doesn't appear to have been a plan B. We're just being presented with, this is it. This is our only chance, and that feels quite unfair, because there feels to be like, if this doesn't happen, something really awful is going to happen to primary care. And it just doesn't feel like this has been planned through. And my other issue, which one of my constituents has asked specifically for me to raise, is this going to mean privatisation in the end? Because what people are worried about is, I know that the GP partnerships are remaining in place for the time being while they move into these buildings. I would be interested to know how many of those GPs are GPs who could potentially retire, who are in their 50s, who once they sell their building will have a nice lump sum and retire early. And we know how many GPs are retiring early. So I don't accept the recruitment argument. I think we'll see a lot of people leaving. I think at the last committee, there was a lot of scepticism about how well all these different partnerships could work together. And they quoted another surgery where this had happened, and where within 2 years there was a private healthcare providing services. And so that's another thing. I mean, how confident are you that these GP practices are going to, that these GP partnerships are going to remain in place?
So there is, I think I picked up 3 key issues there, and obviously there's a lot more than that, because we speak to the experiences of individuals. However, in terms of the time we have here, I'm just going to address the 3 key things that I'm hearing that you were saying to me. So the first one was about really about estate and saying, was any other options considered? So I'm just going to ask Emma if she could just speak as the programme lead around the estate issue and the option B issue.
In terms of the engagement process that we're going through at the moment, it is our intention to collect a number of options from the public, and we already have some. For example, can't you just rebuild 6 new practices, or looking at more other options? So we are definitely collecting those options, and that will form a long list. Once the engagement is finished, the essential and desirable criteria that Tracy mentioned in her presentation will be applied. The essential will be applied to the long list of options. So this won't be the only option on the table. And then from that, we will identify a medium list, for want of a better word. And that's where the desirable criteria that the reference group, the steering group, will determine what those desirable criteria are and the weightings of those. And through that process, that is how we will arrive at a preferred option. So I hope that gives some reassurance that we aren't excluding options at this moment in time.
Thank you. I had a slightly different answer to that question before, so you look at other options. Because I know, for example, in Shifnal, there's the surgery being rebuilt, and it's just that one GP surgery with NHS England money that the then CCG supported. So thank you.
Okay, Tracy and Heather. Because the others spoken at the meeting, I think Chris first, then come back to you if that's okay.
They're still answering. Yeah.
With this new approach, is there any other examples that you've taken from abroad? This?
I'm going back and check in terms of the programme, but this is a national pilot programme, so I need to take back that question.
Yeah, I think that's something similar in France.
I'll undertake to take that back and provide that information.
Yes. Tracy.
Thank you. Thank you. Just the phase 2 engagement, 6 focus groups, 48 attendees, that doesn't seem a huge amount to me. I just wanted, sorry, thank you. I just wanted where that was advertised and who were the attendees for that. The face-to-face ones as well, where did they take place? And were the attendees a mixture of members of the public, primary care? 48 is a huge amount of people over 4 sessions, basically. Thank you.
Detail, or is that something we need to ask Heather to provide the detail for sure?
We need to ask Heather to do this in detail. I mean, I was on one of the focus groups and there was a range of people on it, but I would need to come back to you.
Thank you. That would be useful. Yeah. Thank you.
Right. The IIA, integrated impact assessment, is a vital bit of work. What weight do you give to that? And if you're going out to the public, there has to be robust and deliverable solutions to things that have been raised. In the past, things that have been raised have been given an answer that were never deliverable. And therefore, the public were looking at things that actually were aspiration rather than actually were going to solve the problems. So the weighting and the deliverable solutions to anything are really important. And it will be really important when you come to look at other options as well for other situations across, rather than plan A, any plan B or C.
Really? Can you keep it succinct, please?
Thank you, Mr. Chairman. I will. Bernie Gotchick, Neil Ward. I'm delighted to hear that the integrated care system is planning to be open about these processes. And in the light of this, has the ICS or any part of this group published the initial integrated impact assessment, which was conducted between January and March 2022, and so several months ago? And secondly, how can we fully assess the impact when we still don't know the site? Surely that has a massive effect on the effect it will have on individual patients and others that use the service. When will we know what the site is, the proposed site? Thank you.
So in terms of the iterative nature of the impact assessment, it absolutely recognises that there are other factors that need to be known before a full integrated impact assessment can be undertaken. So yes, that's why it's an iterative process, because we'll need to know that. In terms of the timing of when the proposed site is known, I don't know, Emma, are you able to answer that question?
I can't give a definitive date at the moment, sorry. It should be within the next month or so, but that's subject to concluding discussions and legal terms, etc.
And the date of publication of the integrated assessment,
so I think the
impact assessment in between January and March?
That obviously is an iterative document, so it's not complete. I can take the request to Edna to ask whether that is planned to be published in its forms, or whether that's actually coming to this committee in September ahead of the public consultation.
Thank you, but it was done in March.
I think when that comes back to the committee, I'm sure there'll be some track changes which we'll see where it started from and see that journey you go through.
I have answers to my questions. Yeah, which is the weight and robust deliverable solutions to anything that's come up. And actually, if we're looking at a site now, we ought to also be looking at other options now.
Yeah, sorry. I was talking about travel. I got one answer, but I think there were 3 points I was making. And the travel is really important, because I think this is what will potentially scupper this plan, because the people who are least likely to go as a result of having to travel further are going to be the group of people who we most want to reach, which is people who have health inequalities.
And that's why the weighting is important.
So in terms of the 3 questions that you asked me, I've also noticed that you asked about health inequalities and how we were going to be looking at the fact that health and healthcare services are only, some people say 10, some people say 20% of the impact, and then there's the much wider determinant of health and wellbeing. And to that question, I just wanted to assure you that in terms of the Shropshire Health and Inequalities Plan, it's a joint health and social care plan that myself and Bernie Lee have been working on. So it forms an integral part of understanding that health and health inequalities has to have behind it those wider impacts. You also asked about privatisation, and would anything about the model that we were doing mean that GPs would become privatised. So just to say that GPs are independent businessmen. Yes, there is much in talk in the press about larger companies, but that is a decision for GP practices and not a decision that we would make on their behalf.
Yeah, and I think that was the concern, because these 8 surgeries are all actually a limited company now, Darwin Health Limited, and that is the concern, is that if we get this new building, these partnerships will decide to sell their practice onto a large, possibly American corporation, and it will completely lose the small, local touch of healthcare.
I think Australians are dangerous territory. Jeff, you go first.
No, I still would like an answer to my question. No, I've had it.
Yeah, I know, bear with.
Thank you, Mr. Chair. At the May meeting, I asked a question which was, what's the criteria to decide where you're going to position this new building? Because you've got 6 practices spread over an area, and surely everybody has said in these feedbacks that they wanted to be near them. So would it not make sense to try and put the building somewhere in between, bang smack in the middle? And I know that there's conversations about Mill Brace and so on, because there's probably land available, but I just want to make sure that what is the criteria to decide? And you worry me now saying that you're going to decide possibly within a month. So are you taking into consideration the feedback you put on there about people wanting them to be close to home, easy to get to? What's the maximum distance you're going to let people travel to go to doctors? Because it's stressful enough at the moment.
Thank you, Jeff.
Thank you.
If you put the rating question into that as well.
So in regard to, obviously you're appreciative that I'm delivering this presentation on behalf of colleagues.
Yeah, I know.
So therefore there is information that I'm aware of, that I'm involved in, and then there is some level of detail that I would need to go back and get in for you. But when we talk, so you spoke about how much weight will be given to each thing. So I think that's a question that can be put back, and a response provided for you from the team. In terms of the deliverability of options, and this is always when we go into integrated impact assessments and public consultations, that we look at, can you solve the issue for absolutely everyone? And I like to be completely transparent and honest and say that that's not always possible, but we must consider how best we can mitigate them. But they need to be deliverable mitigations.
And that was my question, really. They need to be deliverable. In the past, we've had a whole load of high-level solutions that were never going to be deliverable.
Travel signs for Jeff.
So your question
is the criteria of how you're going to decide where to put the building. Would it not make sense to give a higher weighting to the views of the local people that want their doctor surgery as close as possible to where they are at the moment? Is that being considered? Or are we purely looking on a commercial basis because there's land available in Mill Brace or whatever?
I don't know the exact criteria because I'm fairly new to the programme, so I wasn't part of that. But I understand that proximity of where we would look to secure a piece of land in relation to the 6 or 8 practices was taken into consideration. And we are listening to what people are telling us, and we do know that transport is as Tracy's mentioned, a major impact and concern for people. Obviously, the other side of that is, in terms of where it is, it's the availability of suitable size, and availability of land will be another determinant.
Are we talking to people who are travel 10 miles or more?
We've undertaken to commission a travel impact assessment, which will feed into the impact assessment that we've just been talking about, so that we know which proportion of populations are affected in what way, whether that's public transport, private transport or walking.
Okay, thank you. Your last word, Rachel.
Thank you. It's just a comment just to clarify, I think, Councillor Holliday's question. I know you'd asked it one at council around, and then there's a follow-up question around hub. So the team have just said to confirm that they are working together with the ICS at the stage around transport and to understand the transport requirements. And that is linked to the impact assessment, because obviously we need to know where that is in the impact. And that will then help to define the model and the cost associated and how that will be funded. There's no sort of set in stone. It could be funded from here. It will depend on the model, and the team are working together. So just to clarify that answer, that you'd ask for a specific response around that.
Thank you, Rachel. I just remind members that this is the start of the journey, and thank you, Tracy and Emma, for coming and sharing your thoughts, because it's going to be an ongoing process. So, thank you once again. Moving on with the agenda, because we are running short on time now. So, item 9, Clark, please. Tom. Okay, thank you, Chair. I won't make the point on the report too much for half an hour at a time. So, for this committee, there are CORT roles. We don't currently use CORTs in council's committees, and there is an opportunity within the constitution for you to identify. We call them time-limited CORTs, so they don't have any voting time. They have access to the information, and they can be part of the meeting. So they can come to this meeting. They could attend task and finish groups. It's about bringing in that external expertise. So in particular for this group, because of what you're looking at, the term that's used now, I'm sure there's a few different ones in the past, is people with lived experience. The people who have had experience with adult social care services, or they're a carer of someone who's using services, or they come from a patient group. It's giving those people a role in that piece of work. So I suppose one bit is, when we come to our work programming, please be thinking about what experiences would be helpful to you to consider those at work. The other bit which is great is we've got Health Watch here. They are able to tap in. So we have got mutually beneficial powers in terms of scrutiny. You can call people from the NHS in, and they come. Health Watch can't call people in, but they can go and have a look and come back and say what really is happening. So we need to make sure we're working that relationship really, really well. The other bit is this committee has a role in confirming 3 permanent co-optees to the joint health scrutiny. So at the moment, the model is Telford and Wrekin Council and Shropshire Council each have 3 elected members of their health overview scrutiny committee. So we've got Steve, Heather and Katie there, and 3 permanent co-optees. So those permanent co-optees represent the Shropshire Council area on that committee with the members, and they have a vote. So it's really important in those matters to make sure we have the right people there, and that they're able to attend as much as possible, because the decisions that will be taken in those committees will be around things like which recommendations we're going to push forward. Has there been a sufficient response to an engagement exercise? So Future Fit, as was a big exercise that committee is looking at. Well, I've been involved since 2003, and it's called various different things, but that joint health scrutiny has been engaged in that work for that length of time. So what we're asking for here in this paper is an agreement that there's 3 different COPT roles we've identified. The first one is Health Watch Shropshire. It says it on the paper there, reason for that, but we just rehearsed that. The other is to ask for a representative in patient groups. So again, very much reflective of the importance of making sure that we are getting that voice heard and understood in whatever's being looked at and whatever's being said. And the third one is around someone with clinical professional experience who can come from the care sector, from the NHS, from the health sector, or from NHS management. It's someone who brings that different perspective in, because no one's expecting you, as the members on that committee, to be the expert on what you're looking at. It's just that additional perspective. So what we'd like to do is we would like to go out for expressions of interest to inform the decision making on those roles. So for Health Watch, they can choose themselves, but it's from within themselves they will choose who their co-optee will be for that committee. And what we'll probably look to do is try and get those expressions of interest in between now and your next meeting in September,
then come back with this is who and this is why. And we can progress from there and then move to the new committees coming into role from, I think there's a meeting on the 20th of October. Scrutiny sort of fixes the cycle to go with that. So in terms of the recommendations, the 3 on there is 1, you're happy with that focus for those 3 qualities, roles. Be happy for us to go out for expressions of interest, which we can then sort of bring back and confirm, and that you're happy to look at the role of people with lived experience informing your work, whether it's a task administrator in the committee as well.
Okay, so we've all had a look at the paper which has been on the agenda, so I'm happy to move from the chair. And is everybody in agreement and go forward with that? Yeah, thank you. So the final item is isolate the work programme. So we have had a online meeting to discuss this last week before, whatever it was. So we don't want to go over the same ground, but Tom,
yeah, so at the moment with the work programme, it was a really good workshop session. I think we've covered off the areas, the main areas. I'm not going to rehearse, go back through those which are in there, but what I suppose the question now is, it's important that scrutiny is member led. So I would like to work with you to make sure that we're clear on the objectives for the topic. It's not come out of my head. It's something that we're all bought into. We're clear on what we expect the value to be, because it's really important that your scrutiny time is value added. So what was a really constructive conversation in the workshop session was, what's a scrutiny item, what's an information item or a briefing item. So when you look through this, there's a list of briefings which will be brought forward. That was from that conversation. They will allow you the opportunity to learn more about a topic, but not in scrutiny meetings. And from those, you might identify more topics to come forward to the work programme. Some of the big ones I think in here are primary care, which we've started now. This is going to roll. It's going to keep on going. Big question around that is access to primary care. We will deal in this committee with things which are Shropshire Council area focused. You will have the opportunity to push up to the joint health scrutiny, things which are more system-wide, whole Shropshire and Telford region. So that's just something to keep in the back of your mind if you feel you need to move into that area, or there are things you're starting to see which are bigger than just Shropshire Council area. We've got the integrated sister care system piece, so I think there's more briefings things coming forward on that. That's a big piece to look at and understand from your perspective. That is more likely to be on what's happening in Shropshire as a place, because the system-wide piece will be what's happening at joint hospital look at. So SHIP, Shropshire Integrated Hub. Thank you. So that would be a big focus on what's happening, and that's going to be quite an interesting thing to get into as well. And again, without going through everything that's on here as well, inequalities plans. So Shropshire inequalities plans, not just health inequalities, it's the whole piece, picking up what we talk about in population health management. It's the whole thing. So that will be wide. When you take that, there will be bits in there you will get into in more detail. You won't be able to look at health inequalities or inequalities as a whole topic, because it is going to be probably too wide. And finally, one of the big bits which came out of that conversation is around rural proofing and health and care services. There's lots of lots of change happening, lots of things coming forward. How much of what's coming forward and what these plans are when they come out of Westminster, for example, how much rural focus, how much understanding of what's happening in Shropshire is, or Cornwall, or Cumbria, or Northumberland, all those areas are very rural. What's happening there, and how is that being played into the thing? So I think you've got a good set of programme topics there to work from. What I need to do is work with you to be able to understand and clearly be able to say to colleagues from ICS and other places, this is what we're looking at, this is what we want to achieve, this is why we're doing it, this is what we want to hear, and this is who we want to hear from. If we can do that really clearly, I think that will benefit you all, but also benefit anybody who's going to speak to you as well, because it just means they can prepare for as long as possible.
Can I suggest we do arrange
another quick workshop meeting to fill in those objectives and those subheadings below the main headings, if you like, so we know exactly. So you can go away and get the right people in front of us in those meetings. Yeah. And, as many of us that can get on that call, the better, really, because it is important. We've got a lot of work ahead of us in the next 12 months, and I want to be sure that we're looking at the right things, not going off and trying to do everything under the sun, but the real critical things which are in front of us. Do we need to improve that? No. Yes. Right, okay then, so thank you everybody, that's we'll get that in the diaries. The date of the next meeting is the 19th September at 10 o'clock here again. So thank you everybody.